Still playing up. Yeah. Okay, here we go. Yeah. So today we are talking about dyslipidemia and what dyslipidemia is. We are talking about dyslipidemia management. I hope you can hear me all very well.
Yeah, we can hear you, yeah.
And you can see my screen?
Yeah.
Thank you, yeah. So what is dyslipidemia? It's basically elevation of the plasma cholesterol, triglycerides, or both, or the low density lipoprotein. It covers a wide spectrum of lipid abnormalities. And it's the interaction of these abnormal lipids which are responsible for cardiovascular risks, which basically contribute to the development of atherosclerosis. It has a linear relationship. There is a linear relationship between the lipid levels and the cardiovascular risk. The way dyslipidemias or the lipids are classified, there are basically two ways. There is the old traditional classification, which is called the Fredrickson phenotype. And there is that one which is based on etiology. It's the one which is based on etiology, which is most used. The traditional one is very complex. So the one which is based on etiology, basically, it subdivides it into primary or secondary. And it uses the characteristics of the lipids. For example, is it pure or isolated hypercholesteremia, or is it pure hypertriglycerides or isolated hypertriglycerides, or is it a bit of both? That is for the newer classification, or the one based on etiology. Then we have this one, the Fredrickson. I'm not going to dwell so much on it because it's a little bit complex and utilizes on the predominancy of the type of cholesterol involved. That's what it uses. So basically in type 1, it's purely mainly because of the chylomicrons, and the chylomicrons mainly consist of triglycerides. There is the 2A, which is the LDL cholesterol, and then the 2B LDL, and the very low density lipoprotein. The third one is the very low density lipoprotein and the chylomicron remnants. Then we've got the fourth one, which has got chylomicrons and very low density lipoprotein. Coming back to the primary, or the one which is based on the etiology, we've got the primary and secondary. So the primary is mainly genetic. It's the genetic. It can be a single or multiple mutations. And basically the pathophysiology, if you're to think about it, is either there is overproduction or there is defectiveness in the clearance of either the total cholesterol or triglycerides, or is underproduction or excess clearance of the high density lipoprotein. The secondary causes mainly are caused by lifestyle, but there are also other secondary causes, as we are going to learn more about it. For the primary, which is based on the genetics, there are so many types which are classified, but the most important is the familial hypercholesteremia. There is the familial defective lipoprotein 10. There is the PCSK9 gain of function. There is the polygenic hypercholesteremia, LPL deficiencies, different. I don't think it's really very important for you to delve into or to know each of the types, but at least understand that the primary is mainly genetic, and it's based on either how much is either there is a defect in clearing or there is overproduction. If we are to go to the secondary causes, which I think most of us should be dwelling on, is basically the sedentary lifestyle with excessive intake of the saturated fat, cholesterol, or the trans fats. Diabetes is a very important cause. Excess alcohol, chronic kidney disease, hyperthyroidism, primary biliary cirrhosis, and other cholestatic liver diseases. And there are some important drugs, for example, the thiazides, the beta blockers, the retinoids, highly active antiretroviral therapies, cyclosporin, tacrolimus, progestins, and glucocorticoids. Cigarette smoking, steroids, HIV infection, nephrotic syndrome. All those are very, very important secondary causes. Now, diabetes, of course, is a very important atherogenic cause. And it tends to cause a combination of both high triglycerides or high, small, dense, low density lipoprotein fractions or low HDL. It's mainly the type 2 people who are at risk. And it tends to be as a result, of course, as you know, because of the syndrome X with obesity, poor glycemic control, or both. So what are the symptoms of dyslipidemia? It's usually dyslipidemia doesn't show any symptoms or any signs of this. However, it can lead to diseases, cardiovascular diseases, which are very, very important and are paramount in this case. Okay. Yeah. So the high triglycerides, especially if you get to a level beyond 11.3 millimoles per liter, it can cause acute pancreatitis. And levels of LDL can also cause cornea arcus. It can cause xanthomas of the Achilles tendon. This can also appear in the elbow, knee tendons, or even over the metacarpophalangeal joints. Now, the homozygous familial hypercholesterolemia may also cause planar and tuberous xanthomas. So severe triglyceridemia, if you get to
did we repeat any CRP, white cell lactate? Did we follow it up, or that was just a discharge?
She did have.
Sorry, was that a question or someone just interrupted? So severe triglycerides above 22.6 can cause retinalis lipemia, which is the creamy appearance of the retinal arteries and veins. And extremely high lipids can also cause lactacent or the milky appearance of the blood plasma, which is associated with paresthesias, dyspnea, and confusion. How do we diagnose dyslipidemia? Of course, we have to measure the serum lipid profile. Can everybody hear me again? Can you hear me?
Yeah, carry on.
Yes.
Yeah, carry on. We can.
Thank you. Yeah, sorry, someone is ringing me all the time. I think is wondering whether I'm able to connect with you. Yeah. So dyslipidemia is suspected basically in the patients who are having findings or complications of dyslipidemia, of atherosclerosis. Of course, if somebody presents with a premature atherosclerotic disease, it should ring a bell that most likely dyslipidemia is a very important cause. There are also those people who come with a family history when they attend for different conditions and they have got a family history of atherosclerotic disease at a premature onset, or even if not at a premature onset, but if they say it is familial, you should always take onus to check their lipid profile. So the lipid profile measurements, essentially you should measure the total cholesterol, the triglycerides, and the HDL. Those are normally measured directly. Now, the total cholesterol can vary by 10%, while the triglycerides can vary by 25% on a day-to-day basis. The old recommendation was that this should be done when fasting, or better after 12 hours. But there is a lot of tendency now to diverge away from that. And people are no longer following that. But now you can easily take the on-spot or the random measure, because the emphasis now is going on the non-HDL, which is as an important marker of how to manage the cholesterol. So how do we calculate the different types of cholesterol? The LDL cholesterol is, of course, that's the bad cholesterol, is calculated as the amount of cholesterol not contained in HDL, or very low density lipoprotein. So normally, and you're going to ask me what is very low density lipoprotein. So very low density lipoprotein is always a fifth of the total triglycerides. So if you want to establish the measure of LDL, the way you measure it is the total cholesterol minus HDL plus F plus what you get after you divide triglycerides by 5. So, however, this calculation is varied if the triglycerides are less than 400 micrograms per deciliter for patients if they are fasting. And patients normally are fasting as eating increases triglycerides. So if you're interested in really knowing how much triglycerides, in this case, you may ask them to fast. So triglycerides can also be measured by ultracentrifugation. You should always do assessment, of course, for secondary causes in addition to these measurements. So is dyslipidemia important? Of course, it's important. We've talked about why, as we are going ahead, why it's important. But I want also to emphasize that, obviously, you all know this. It contributes strongly to cardiovascular disease, like coronary artery disease, like stroke, like peripheral arterial disease. And it's important in the pathophysiology of cardiovascular disease through atherosclerosis development. So in England and Wales, we all know that cardiovascular disease is still the leading cause of death. As the figures have put there, unfortunately, they are for 2010, but 180 deaths were directly as a result of this, with 80,000 due to coronary artery disease and 49,000 due to stroke. It unfortunately affects disproportionately. The males seem to be more affected by, especially when you are above the age of 75. So the death, despite this, the deaths have been falling in the older age group compared to the young. The morbidity, however, has not changed. The morbidity is still there, actually, or I think it's still on the rise, although the mortality has improved. The financial implications of this are, of course, enormous. And it was estimated in 2010 that almost 8 billion was spent on just this, okay? So cardiovascular disease, of course, shows a strong correlation with age and predominantly affects those, especially when you are 50 years and over. So risks for cardiovascular disease. The risks, of course, they include what we call the non-modifiable and the modifiable ones. So the non-modifiable ones basically are the ones where you can't do anything. For example, age, sex, family history, ethnic background. And the modifiable ones are the ones where you can do something about them, like the smoking, raised blood pressure, cholesterol, low income, social deprivation. I know some of you might object and say social deprivation and low income probably can't do anything about it. So how do we manage dyslipidemia? Management involves identifying and assessment of the cardiovascular risk, and basically lifestyle modification for the primary and secondary prevention is very important. And of course, it involves lipid modification therapy or treatment for primary and secondary prevention of cardiovascular disease. So how do we do cardiovascular risk assessment? There are different tools, many of them actually out there, which are being used to assess for cardiovascular risk. But the most commonly used ones, for example, are the ones which are mostly utilized in the United States and in Europe. So the oldest one, which has actually been so much in use, is the Framingham Risk Score. There is the Reynolds Risk Score. There is the American College of Cardiology or American Heart Association Risk Score. And there is also what we call the Q-Risk. So in Europe is the Systemic Coronary Risk Evaluation and the Q-Risk 2, which is commonly used to assess for cardiovascular risk. These, of course, take into account the patient's lipids, as well as his other risk factors like the modifiable ones and the non-modifiable ones. In the UK, NICE recommends the Q-Risk 2, while the European Society recommends the score. The score one is called the score. And the risk assessment tools they only provide an estimate. It's like they don't give you an actual value. They just give an estimate of your risk. It's not like an absolute assessment. So there are some people, however, where these tools do not apply. For example, if you have diabetes mellitus type 1, or you have a low EGFR, or you have albuminuria, so these people normally are at increased risk of cardiovascular risk. Risk assessment, they are also likely to underestimate, the tools are likely to underestimate the risk for people, especially those who are being treated for HIV, those on mental disorders, because they're kind of like their diet may be varied from ours, but also the medications they use may also cause the dyslipidemia and put them at increased risk. So people, especially who are taking antipsychotics, corticosteroids, or people who are on immunosuppressants, these people also tend to be at increased risk of cardiovascular disease. Always consider people above the age of 85 to be at increased risk, and most of these risk scores don't take them into account. So, what are the lifestyle modifications for primary and secondary prevention of cardiovascular risk? Of course, this is what we call the cardioprotective diet. So you advise that you should not eat more than, at least you should eat less than 30% gram of total fat of the total energy intake, less than 7% of the total energy intake of fats, and less than 300 milligram per day of cholesterol. And you also advise to take on to have a increased diet containing whole grain varieties like starchy foods, reduced sugar intake, eat 5 portions of fruit per day, eat 4 to 5 portions of unsalted nuts, seeds, and legumes per week. Coming back to the first one, I'm not sure that many people really can observe this, because how many people can measure that now this is less than 30% of the total fat, this is less than 7% of saturated fat. In brief, I think if I would sum it, I think always eating a healthy, balanced diet, to me, is the best. But for the purpose of this lecture, of this talk, we'll continue giving you what is recommended, although what is recommended may be very difficult to adhere to. So, of course, physical activity is very important. You are advised to do 150 minutes of at least moderate intensity aerobic exercise per week, or 75 minutes of vigorous intensity aerobic exercise. Of course, doing more is important if you can afford to do more than this. However, there has been a study also which has shown that if you do too much, especially of vigorous intensity exercise, that actually can also harm your heart function. It can cause the heart to become impaired in terms of its function, because it's like a shock to it. So of course, weight loss for those who have got a lot of weight is recommended. Reduction of alcohol consumption, smoking cessation, and avoid plenty sterols and stenols. So coming to treatment, that was the lifestyle advice. How about treatment using medication? So for primary prevention, atorvastatin 20% to those at least having a 10% or greater cardiovascular risk, a 10-year cardiovascular risk of developing cardiovascular disease. And consider always also atorvastatin 20 milligrams to those over 85%. I mean, over 85 years of age, also to be at increased risk. Now, if you come in with a heart attack, especially with a STEMI, it's always recommended you take 80 milligrams of atorvastatin. Of course, there are some people who are always having potential drug interactions. Those you should consider reducing the dose, or those who have other drugs where you may end up with a lot of adverse effects. And in some people, some patients may not prefer to be on the high dose. So you should also consider reducing the dose. Now, when you're talking about statins, the statins can also be graded into high intensity. When they say high intensity statins, they mean those which are likely to, which will cause at least a 40% reduction in LDL cholesterol. Now, so those which are considered to be high intensity statins is at least atorvastatin from the dosage of 20 milligrams to 80 milligrams, that's high intensity. And rosuvastatin 10 milligrams to 40 milligrams. Simvastatin is only when it's at 80 milligrams, that's when it's considered to be at high intensity. Medium intensity, those ones reduce cholesterol, the LDL by 31 to 40%. That is atorvastatin 20, simvastatin 20 and 40, fulvastatin 80, and rosuvastatin 5 milligrams. How about for the low intensity LDL reducing statins? So if you give simvastatin of 10 milligrams or pravastatin of 10 milligrams or even 40 or fulvastatin 40 milligrams, just know you are aiming to reduce the cholesterol by a very small proportion. So it's always advisable to use the high intensity statin to achieve a quick reduction. Non-HDL is now recommended, like I said, when deciding on statin therapy. And the basic blood test, of course, before you start all this, you should do some blood tests before you start the statin therapy. So we said total cholesterol, non-HDL cholesterol, HDL cholesterol, triglycerides, renal function, TFTs, HbA1c, LFTs, all those should be looked at before you start treatment. We say that people with diabetes type 1 are always at increased risk. So always initiate the high intensity statin. So that will be atorvastatin 20 milligrams. Or if you decide to use simvastatin, then you're going to go for 80 milligrams. If they are 40 years or older and have had diabetes for 10 years, have established nephropathy, or have got cardiovascular risk, there is no doubt you should always start the high dose statin. If they are diabetic type 2, they also have an increased risk. So 20 atorvastatin 20 is recommended. Says the same applies to people with CKD. Your aim is to reduce their total LDL or total cholesterol at least by 40% about the reduction. That is focusing on the non-HDL especially. So how do you follow these people up? When you follow them up, for example, if you initiate statin today, your next check of cholesterol should be within 3 months. And of course, you're going to measure the total cholesterol. You're going to look at the HDL. You're going to look at the non-HDL therapy. Aim for 40% reduction. If you've not achieved that, of course, you're going to explore other things like adherence. Is the patient taking it? Timing of the dosage. Is how about the other factors which may be contributing to the high rise in cholesterol? How about his diet? You should look at it. Other lifestyle measures, for example, is he drinking too much? Is he still smoking? And if you explore all these and it's not working, then you're going to you might have to increase your statin to get to where you want. And always provide, of course, annual medication review just to look at that someone does not stay on. There are some people who remain on a statin therapy indefinitely without really any beneficial use, or especially if they have got no significant risk factors. So there are some adverse effects which can be associated with statin therapy. Grapefruit is known to interfere with the statins, so you should always advise them against using it, especially when actively on treatment with statin therapy. Before starting statins, ask patients if they have got generalized muscle pains. And if present, of course, you're going to check the CK. Now, if CK is more than 5 times, more than 5 times the upper limit of normal, it's recommended not to start the statin therapy. Because it tends to fluctuate, you are advised to remeasure it after a week. If you remeasure it after a week and it's less than 5 times the upper limit of normal, you can start the statin therapy. But if it's more, then you better leave it off. Okay. Now, there are some people who will come and they have got a little rise in the transaminases. If somebody's got a transaminase rise of not more than 3 times the upper limit of normal, normally you shouldn't stop the statin therapy. So if for example, he's got a little rise in transaminases, you can start statin therapy without any problem. Do not stop statins due to increase in HbA1c or blood sugar levels. And of course, you should remember that the statins are teratogenic. So if someone is planning to have a family or is pregnant, always you should consider stopping them and look for alternatives. If intolerant, of course, you should avoid them and aim to treat with other maximum tolerated medication which is available. So there are other treatment options, although they are not mainly recommended, especially in the UK. There is fibrates, there is nicotinic acid, there is bile acid sequestrants, and omega-3 fatty acid compounds. You're going to ask me, fibrates actually, they can be used, but under specialist guidance, and they tend to be especially for people who have got like triglycerides, which are likely to cause either pancreatitis or at risk of causing other problems. So when somebody, for example, has got very high triglyceride levels, but they shouldn't be started on a normal day-to-day basis. And remember that actually fibrates are also very notorious for causing muscle breakdown and are associated with high CK and are likely to cause muscle pains and muscle aches. So these are not, like I said, are not on our guidelines for statin therapy. I mean for cholesterol reduction at the moment in the UK. There are other medications which you can use as alternatives. Suppose they can be used as alternatives or as an adjunct, as an addition. There is ezetimibe, especially if somebody's got primary hypercholesteremia, and can also be if somebody you've tried a statin, you're the maximum, let's say 80, and still his cholesterol levels, when you measure it again after 3 months, is still very, very high. There are other medications like alolicumab. These are PCSK9 inhibitors. They are also recommended as an option for treating primary hypercholesteremia or mixed dyslipidemia. So these are newer medications, and most of the time they are given as injections, and they are given at intervals. They are not on a daily injections. So they are at the moment, I think not very, they have been recommended on NICE guideline, but still in a DGH, or they shouldn't be initiated unless at least under specialist guidance. Okay, so in brief, I wanted to make things simple, just for at least for my colleagues, the junior doctors, to know when to start therapy, starting therapy, and how to investigate for cardiovascular risk. So I'll stop there unless somebody has got a question, and I'm happy to answer it. Anybody with a question, please feel free to talk.
Alex, excellent talk, nicely summarized. A few things I wanted to clarify. Type 2 diabetes, you didn't include for the risk stratification. Was there a reason that only type 1 diabetes is not suitable for risk stratifying?
In general, diabetes is considered to be a high risk.
Yeah, so both will be. So
Yeah.
no need to do the risk scoring.
Yes, you should start with
either type 1 or type 2 diabetes.
Yeah.
Okay. The other thing was the elderly above 85.
Yes.
Is there good data that we should be starting them for primary prevention?
So there is a paucity of data regarding the over 85s. The data available is not a lot, because most of these risk scores have been based on people who are less. So, but there is some data which has shown that actually there is a lot of mortality related to cardiovascular risk at that age group and above. Hence the reason to assume that they're actually high risk and should be treated aggressively, like among people with high risk cardiovascular risk disease. So they are considered to be among the category who have more than 20% annual, 10-year cardiovascular risk for for cardiovascular disease.
Very good point. And the other point that you made, which I liked, was that instead of going for 4 and 2 total cholesterol and LDL cholesterol of 2, we are going with 40% reduction nowadays, isn't it?
Yes, that's what we are going for. That's right.
And the last one is the outcome trials with omega-3 or any fibrate medications. There are some good outcome trials with omega-3 fatty acids, isn't it?
So at the moment, I'm not aware of anything which has really shown the omega-3 to be very, very valuable. I was looking at there was a summary I was reading from the European study talking about other treatment modalities. But when I looked at the NICE, they do not recommend them. So I did, because they are not recommended, I didn't delve so much into reading more into it.
Thank you very much.
Yeah, thank you very much.
Any other question, anybody? You can put it on chat box if you want.
Yeah, please feel free to ask if you have any question. Okay, Thank you. It looks like there is nobody else with a question. Thank you very much, and thanks for being patient.
Thank you.
Have a good day. Yeah.
Thank you very much. It was an excellent talk and nicely summarized. Thank you.
Thank you very much. Bye-bye.
Thank you. Bye.
Bye-bye.